Good evening, everyone. I'm going to speak about antibiotic stewardship in obstetrics and gynecological practice. Why we are talking about antimicrobial resistance? Because the world is concerned about it. AMR is one of the top global public health and development threats. Recent years, AMR contributed to 4.95 million deaths worldwide. There's misuse, overuse of antimicrobials in human, and it affects almost the entire world. And of course, we have to understand it's a great risk for modern medicine. It puts lot of things into trouble because we are seeing in our day-to-day practice that most of the common antibiotics that we are using, the bacteria are becoming resistant to it. So when we have treatment problems are there in surgery, sections, cancer chemotherapy, and world faces an antibiotic pipeline and access crisis. There is inadequate research and poor development of pipeline matter of concern. So what about Indian scenario? There is 2,97,000 deaths attributed to antimicrobial resistance and more than 1 crore deaths associated with antimicrobial resistance. And India has the 144 highest age standardized mortality rate by 1 crore population associated with AMR across 204 countries. So we have to see from this chart, the commonest death is due to cardiovascular disease, chronic respiratory disease, but antimicrobial resistance is one of the important cause of morbidity and mortality of the patients. There are 5 pathogens which we have to be aware: E. coli, Klebsiella pneumoniae, Staph aureus, Acinetobacter baumannii, and Mycobacterium tuberculosis. All these are becoming very quickly resistant to the common antimicrobials that is available. So why we have to prioritize? We have to prevent all infections. Are we preventing inappropriate use of antibiotics? Ensuring universal access to quality diagnosis, appropriate treatment of infection, and of course we have to tell our patients, we have to give antibiotics only when it is necessary. Most of our patients are taking over-the-counter antibiotics. Once they have symptoms, they take 2 doses or 3 doses of antibiotics and they stop taking the antibiotics. And then again after 1 or 2 months, if they have the same symptom, they repeat the same prescription on their own without coming to the doctor. So it's a population, patients who are responsible for this antimicrobial resistance. And of course, over-the-counter drugs that our pharmacist friends are giving to the patients. They will not come to the doctor, they will go directly to the chemist and they will take the antibiotics from them. So this is all leading to rising antibiotic resistance, and it is a cause of worry for today's practice because very few new antibiotics are being developed. Though we are seeing so much antibiotic resistance, and this is a growing public health emergency which needs to be addressed. So big pharma institutions have left working for new antibiotics and have started working on drugs for cancer, neuropsychiatric conditions, and endocrine, blood and immune disorders because they are more profitable. And they are not working for newer and newer antibiotic developments. So there is a dry antibiotic pipeline, and rising resistance will definitely have bad impact on patient therapy in the future. So this is the brief glance of new antibiotic launches in the last decades, and they are very few. You can see very few new antibiotics have been launched in last decades. So with so few new antibiotic approvals worldwide in past decade, world will move into phase of antibiotic crisis in upcoming years. See, we had an era when there was no antibiotic, pre-antibiotic era, when we had to combat the infections by a natural immunity. Then came the antibiotic era, and the world was flooded with antibiotics. And we have used antibiotics right, left, and center. And now most of the bacteria are developing resistance to those antibiotics. So in the end, we'll have very few antibiotics which will work. So when we have limited resources to run household, we measure each spending judiciously, and the same thought has to come while we are using antibiotics. We have to use our antibiotics very judiciously, only when it is required, only the dose that is required, only the duration that is required. So the future of antibiotics depends on all of us, each and every one of us who is using the antibiotics for our patients. India's confrontation with AMR reached global headlines in 2008 when a new multi-drug resistant strain was discovered in Swedish traveler infected with a common bacterium, that is Klebsiella pneumoniae, and it was named as New Delhi metallo-beta-lactamase, a key moment in the rise of India as a major player in the emergent antimicrobial resistant crisis. So Gangaram study finds high levels of superbug, and this was published in 2011, and it created ripples. It has been more than a decade this news had created noise levels, waking up ministries and health bodies. Returning to the Indian context, despite repeated warnings from the WHO, it took nearly a decade for the problem of antimicrobial resistance to be openly addressed politically. Even our Prime Minister, Mr. Modi, in Man Ki Baat 2016, he talked about antimicrobial resistance as a serious crisis, Gambhir Sankat. He also stressed that the Indian population takes the medicine over the counter without consulting doctor, and they will, without issue of appropriate dosage, without listening to taking avoidance without prescription, and finish the course of antibiotic even if they felt better. So what they do, our own patients, they use overuse or misuse of antibiotics. Of course, there is lack of awareness. They do not understand that if they take inappropriate drug for shorter duration, then it raises bacterial resistance to that particular antibiotic. Of course, there is poor infection control, lack of regulation in animal husbandry. Antibiotics are commonly used in animal farming as growth promoters and to prevent disease to the cattle. However, this can lead to antibiotic residues in meat and other animal products. Most of us are using milk and milk products, and this is directly or indirectly transmitted to us without even we knowing or being aware of it. And this slowly may cause antibiotic resistance in us. We may be thinking that we are not taking antibiotics judiciously, but this indirect intake of antibiotics through milk and milk products or maybe animal products, this can lead to antibiotic resistance in some of us. Of course, there is limited access to clean water, inadequate surveillance regulation, and of course, there are challenges in the pharmaceutical industry. So what are we trying to do? We want to do a strengthening of regulatory oversight of antibiotic use. We want to invest in healthcare infrastructure, public education. Of course, we have to have a surveillance of antimicrobial resistance, and of course, we have to have a collaboration between the private and public sectors. So they are seeing that Indian studies and review have pointed the existence of inappropriate and irrational antibiotic in obs and gynae. There's a multiple studies which shows that obstetricians and gynecologists are using antibiotics which are not so necessary without diagnosis, and then we have to think again and again when we are using the antibiotics for our patients. So there is a need of antibiotic stewardship, so that a coordinated use of antibiotic in order to improve patient outcomes, ensure patient safety, and also combat antibiotic resistance. We have to optimize antibiotic use, doses and duration, preventing antibiotic resistance, surveillance and monitoring, education and communication, and policy implementation. Why it is necessary? Because there is a unique physiology of pregnancy, and we have to think of antibiotics, we have to think of risk of maternal and neonatal infections, fetal safety, antibiotic prophylaxis, prevention of perinatal infections, these are important. And when we are doing of intrapartum antibiotic prophylaxis for group P streptococcus, we have to manage UTIs, minimize antibiotic resistance. Monitoring and surveillance is important. So there are 7 elements of hospital stewardship. We have to have a hospital leadership. In our hospital, almost every month, Dr. Wattel, who is the head of the microbiology department, he sends us a communication with how many antibiotics are we using and what is the result of the hospital drug resistance in our hospital. And that communication between the clinicians as well as the microbiologist is important in all the tertiary care hospitals. So we only have to write a simple and big application, and it is just easy and fast. Implementation is not so easy. We are talking about challenges, we are talking about researches and what to do. We have to have a patient's factors, we have to have empiric judgment, and of course we have to have a source of income for pharmacies in small hospitals. But what are the factors which guide antibiotic selection? We have to first diagnose a condition, think before we prescribe antibiotics to a patient, and of course we have to think about the duration, doses and everything. So what are the challenges? There are competition among doctors, absence of a champion, utility value of an antibiogram, poor enforcement of regulation, time constraints. So sustainability measurements are there. We have to have a universal antibiotic policy, collective responsibility, incentives, availability of microbiology culture facility, feedback system and community awareness. And we have miles to go. So best way is to save antibiotic. Each one of us to become responsible stewards in antibiotic use. And we obstetrician gynecologists have to contribute a lot. So if we want, we have to follow the guidelines. What are the guidelines? ICMR guidelines are there, which says, what about UTI in pregnancy? Nitrofurantoin is a category B drug, cefalexin is category B, erythromycin is category B. So we have to think about the ICMR guidelines, which has very nicely proposed which antibiotic to be used. Vaginal delivery, we can use either ampicillin, which is the preferred drug, or if there is an alternative drug, we can use cefazolin, and if allergy, vancomycin can be used. Third or fourth degree perineal tear, single dose cefotoxim or cefotetan. If there is alternative drug, cefazolin 1 gram IV can be given, or single dose amoxicillin clavulanic acid can be given. Preterm labor or premature rupture of membranes, IV ampicillin 2 gram followed by 1 gram 4 to 6 hourly, or erythromycin can be given. Caesarean delivery, single dose cefazolin, or if allergic, you can give clindamycin and gentamicin. ICMR has given lovely guidelines. Rescue cervical cerclage, ampicillin. Puerperal sepsis, piperacillin tazobactam. Alternative, clindamycin or ampicillin sulbactam. For hysterectomy, whether abdominal, vaginal or laparoscopic, cefazolin 2 gram IV single dose or cefuraxim can be given, and if allergic, you can give clindamycin and gentamicin. Laparoscopic or hysteroscopy, then you can give cefazolin or cefuroxim as an alternative drug. Abortions, azithromycin. Alternative drug is doxycycline. HSG, doxycycline can be used. Pelvic inflammatory disease, preferred is cefixim or metronidazole. Alternative, levofloxacin, ofloxacin, ceftriaxone and doxycycline. Pelvic inflammatory disease, if it is severe with tubo-ovarian abscesses, cefotetan is a preferred plus doxycycline, but alternative can be sulfaxetine or clindamycin. Vaginal candidiasis, fluconazole is preferred. Alternative can be miconazole or nystatin vaginal tablets. Vaginal candidiasis, fluconazole or alternative can be miconazole. Vaginal trichomoniasis can be secnidazole or tinidazole. Bacterial vaginosis, metronidazole or metronidazole, we know all these things, but most of the time we are using mixture of drugs. So we have to reserve, watch, and access. In prescribing antimicrobials, we have to choose the right patient, right time, right dose, right route, right duration. Then and then only we can prevent resistance of a bacteria to the common antibiotics. So what more can be done? To decrease infection, we have to decrease the use of antibiotics. And of course, we have to decrease the morbidity and mortality from antibiotic resistance. So we have to be aware, updated, and of course, we have to have self-education as well as the patient education. We have to keep our eyes open on newer developments. Is there any new antibiotic approved? One must be aware of new antibiotics approval. Treatment of resistant infection is important. We have to broaden treatment options and improve efficacy and safety of the patient's use of antibiotics. So we have to reduce treatment failures, we have to combat emergency threats, and of course we have to tailor treatments also. So there are new drugs in the practice which is coming. Martyrdom, that is ozenoxin, which is DNA grace inhibitor, DNA topoisomerase IV inhibitor. Common indication, gram positive, MRSA, acne impetigo. Levonardisofoxlin, which is a DNA gyrase inhibitor. Of course, MRSA, acute bacterial skin and skin structure infection. Ceftazidime and avibactam, non-beta-lactam, beta-lactamase inhibitor. Gram-negative complicated urinary tract infections, and biopenum, because this is also beta-lactamase inhibitor for gram-negative and gram-positive aerobic and anaerobic bacteria. And these are given parenteral. So this is martyrdom, which is better drug, and of course we have to use them very judiciously. We don't want bacterial resistance to them. And with broad spectrum, they are broad spectrum, we are looking forward for better results. We have to liaison with microbiology department. Education and training is important, patient education is important, and of course with the concluding remark, antibiotic stewardship in obs and gynae is of paramount importance to ensure optimal patient care while mitigating the risk associated with antibiotic overuse. Adopting and implementing effective stewardship practices, we can improve better care to our patients. We have to preserve antibiotic efficacy. We have to ensure patient safety. We have to prevent complications. Then and then only we can have global health impact. Resource utilization has to be done judiciously, and of course we have to adhere to the guidelines. In essence, antibiotic stewardship in obs and gynae is not just a prudent practice, it is an ethical responsibility of each and every people that we are practicing medicine. By incorporating these principles into daily clinical practice, healthcare professionals contribute to the sustainability of effective antibiotic therapy, safeguarding the health of current and future generation. Through ongoing education, collaboration, adherence to best practice, the field can make a substantial impact in the global fight against antibiotic resistance. Thank you for your patient listening.
Thank you, madam, for beautifully bringing out the concept of resistance, antimicrobial resistance. The super bug, as we call it, these are bacteria, fungi, viruses who develop a speciality to fight against the drug which was made to kill them. And that is what the super bug is. How are we going to tackle this problem? Because this is the major problem which our countries and the developing countries are facing because of the widespread use of antibiotics, especially by the, let's say, by the non-medical professionals also. The medical officers, the village compounders, nurses who go on, learn from the hospital and start using them for everything. So we need to be, as you said, literate, antibiotic literate. And maybe in the future we could probably be developing a gene which will go into a bacteria, into the bacterial plasmid, introduce this into that body which is showing an antibiotic resistance, and let the bugs fight each other. And of course, we must always remember that microbiome, your own microbiome, is your best defense. So if you are going to kill your own bacteria, the good bacteria which you have inside you, the bad bacteria are going to take over. So that is what my thoughts are about the antibiotic resistance. Thank you very much for bringing it out.
Thank you, Dr. Mala, for such a good topic, that is antibiotic stewardship in obstetrics and gynae. And it is a very rarely discussed topic in our specialty. So we have brought upon this important topic and make us once again, careful towards it. And it is not only the responsibility of the clinical practitioners, but also the policy makers, the pharmacists, and the animal husbandry people. There are so many people who have to be involved in this whole process so that we can make it successful in our country and we can prevent from these organisms from becoming resistant to antibiotics and reduce the, just as I saw the data, people dying out of drug-resistant organisms. To reduce that, that is a real menace that we will have to take up this topic very seriously and work towards it. Thank you very much for such a good presentation.
Mala, that was an excellent presentation, and I must say the choice of the topic was so good. In fact, when you actually elaborated on the kind of antimicrobial resistance that we are facing globally, it was quite shocking. We do talk about drug resistance and all that, and we have to be careful, etc. And we do have, as clinicians, an ethical responsibility, like you said, that it is all clinicians sitting over here, it's our responsibility not only to give them, prescribe them medicines, but also to make it clear to them that this is, you have to take a full dose and don't cut it short, and why not to go on to the next. The importance of medicine is very, very important, which has to be told to every patient, because they are the ones who are going to be probably spreading it amongst their family members. So that is something extremely important. And also to tell them that any antibiotic that whenever we prescribe should be corroborated with evidence of culture. Like you said, cultures are available today everywhere. And of course, the tendency of all the patients just to go over to the pharmacy and just pick up the medicines, whether it is in the village or even my friends just do it. They would just feel relief by taking for 2 days an antibiotic and they'll just stop. And next time when they have a problem, they'll just self-treat them, So that's something which should not be encouraged. And the most important thing, like what you said, is very important. If you're working in a hospital, there should be a stewardship which should be in place, and we all should follow the leader, one should say, and it should be periodically being looked into. It's a very, very important thing, considering the kind of the crisis that the whole globe is undergoing. So it was a wonderful topic, Mala, and I must appreciate the kind of, you brought out facts so beautifully. Thank you very much.
Good evening, Dr. Mala. You have raised a pertinent issue of antimicrobial resistance and how to tackle this issue. This is an area of concern, especially for developing countries and for us. What are we going to hand over to our future generation? That is the main thing. And we have to be careful about, first is the hospital setting, what is being done in the hospital. In hospitals or in health centers or corporate hospitals or wherever we are treating the indoor patients, it is the antibiotic policy which is very important. ICMR has given a guidance and they have looked into this issue because of the problem which we are facing. But it is the local policy of each center which will definitely going to run the show. And we have seen ICU and ventilator associated drug resistance, antibiotic resistance. And in local center, these microbiology department is a very important department to look into these aspects and prescribe the antibiotic policy. And accordingly, all purchases and everything should be directed into. But that is the system which is lacking in our place. The second issue which is important is from the patient perspective. We are counseling the patient. We are now aware that we have to tell the patient that he or she has to take the medicine for this particular day, for this particular duration. But the problem is at the ground level. There are two issues which we have to address, and I think this is the time probably the cooperation and all the efforts by all of you is needed, that the drug is costly, compliance is the issue, patient goes to the chemist, pharmacy or chemist are the prescriber. All drugs are now over the counter. So very easy to procure the drug, number one. Number two is patient can't afford the antibiotic. The cost is so high. You see, if you stand at the chemist shop for 15 minutes, you will see the patient is first asking the cost and then take home only one dose because he or she doesn't have that money to buy the drug. So whenever he or she has the money for second dose, that time the patient will come to the chemist and buy the second dose. So how can you expect the compliance, and all these will lead to the drug resistance? So there are multiple factors, social as well as the professional factors, which we have to look into. And probably this is the time that government has been given a direction that everyone should be looking into this issue. Thank you very much.
Thank you so much. Thank you so much, Dr. Mala, for that fantastic presentation. And I think it was an eye-opener, it was an alert for all of us. We never went into the data that more than 1 crore is attributable to antibiotic resistance. And so I think that this is the right time to stamp down all the antibiotic overuses. And yes, the hospital stewardship programs would be helping us a lot. And I think there should be categorically SOPs to use which antibiotic for which, and that's going to bring, patients change their doctors, I think, because of the recurrence of infections also. And that's just increasing the cost for the adverse effects. So we can bring down the cost, and I think we can bring down the resistance, and also we can bring down the health of our patient and also improve on our microbiome. So thank you so much once again for the same.
Yes.
The way patients get medicines from chemists, that will be stopped if antibiotics can be given only by prescription of a doctor.
So there is a law already to this effect.
But it's not being followed.
How difficult it is. You can't make the government responsible for looking at every damn thing. So I think we should be looking at that.
No, we look at it.
And the Pharmaceutical Association should be looking at that. Yes. That the chemist should not be. See, for running a chemist shop, you have to have a pharmacist. How many chemist shops have a pharmacist? None. They're just on paper with a license taken. So they actually run by people who are not even 10th class pass or something. And sometimes they're giving the wrong drug. A similar name, so that's given. So that's a major problem which is there. Yes, it's a major problem. So all of us should be looking at it.
Thank you so much for that excellent presentation and very engaging discussion.
Sir,
we have one more question.
Yeah. Sir, I have a small issue. These
Yes.
guidelines, can this be applied pan-India from a big hospital in Delhi to a small hospital in Lakshadweep? Is it possible the same guidelines will apply in a village and in Delhi?
So the guideline is there which should be applied.
It's not possible, sir.
It is not applied, that is the problem.
How can you expect a hospital in Delhi with the ICU, with the sterilization, and same expectation in, say, a remote part? 90% of India is rural. These guidelines, I think, are for the urban hospitals.
No, they're antibiotic guidelines in what disease we should be starting with what and what culture and what.
No,
so
I'm
it's
saying,
an
sir,
guideline, guideline, it's not a hospital-based
No, I'm saying, because see, once you operate in a good setup, you can give one dose of antibiotic. Once you operate in some remote place,
Guidelines, sir.
Are guidelines which can be followed by anybody anywhere, and we all, just like we'd follow the RCOG guidelines, we are not sitting in America or anywhere, or you just follow the guidelines, and there are ICMR guidelines available to us.
So let me just
thing is,
Mala, let me just ask them, how many of you have read the Foxy guidelines on antibiotic? Or the ICOG guidelines on antibiotic? You're all Foxy members, no? We as presidents every year work out to get these guidelines out, and they're on the website, they're on our site. Rishikesh has worked out 17 guidelines in last year. How many of you read one guideline at least and are following it?
And I
Nobody
think,
knows. So who are, you want me to come to the village and say, follow this guideline or you'll be jailed?
And
The
I think
guideline
it's,
is given to you. Now the responsibility is yours how to follow it or not.
All the hospitals have to take the responsibility, I think, of following the SOPs and to put it there.
We have guidelines. We have 35 guidelines of Foxy on our website. Just go to foxy.org, read all the guidelines. Everything, there's a guideline for premature labor, there's a guideline for cervical cerclage, there's a guideline for progesterone use, there's a guideline for everything is there.
Our own hospital guidelines, which are based on the ICMR guidelines. Yeah. So, but we should adhere to that, and periodically they should be checked, SOPs should be made. And of course, the practicing physicians are so many. Look at the large number. It is, well, it can be only reminded, reiterated in various forums, I would say. If you have a suggestion, please. Dr. Ashok, you come out with them.
So thank you so much for the deliberations. I request